Good morning and welcome to our webinar, The Interplay of Gender and Mental Health, a Global Health Issue. I'm delighted to say that this webinar was co-organised by the European Psychiatric Association and the European Institute of Women's Health. Our two organisations signed an MOU, a Memorandum of Understanding, in 2022, which formalised our collaboration in the area of gender and mental health. I would wish to sincerely thank the European Psychiatric Association for all their dedication and hard work in making this webinar a reality. So I just have a few housekeeping points to make before we start. This meeting is being recorded. And secondly, participants online, if you'd like to ask the speakers a question, please do so in the Q&A at the bottom of your screen, not in the chat. So I wish to welcome our expert speakers, our moderator, panelists and guests. I want to give a very special mention to Deirdre Clune, MEP, and thank her for hosting the webinar today. I would also like to thank Deirdre for her hard work as an MEP in promoting better health for all, and specifically promoting gender and women's health. Deirdre is a founding member of the Women's Health Interest Group in the European Parliament, which we will launch on the 23rd of October. And the group supports the EIWH 2024 Manifesto for Women's Health, and along with 20 patients, NGOs and research organisations, is calling for an EU strategy for women's health. You can read more about this following the link posted in the chat. I want to give a very warm thank you to our keynote speaker, Lydia Lazzari, the Regional Advisor for Mental Health at the WHO Regional Office for Europe. Unfortunately, Lydia could not join us live, but she has been so kind as to prepare a video message for our webinar today. Thank you very much, Dr. Lazzari. I wish to also give a very special mention to Miriam Schuyler-Osak, the European Psychiatric Association board member, and she's also a member of the European Institute of Women's Health Board, and also Rutger van der Gaag, who is also a European Institute of Women's Health Board member. Rutger will moderate our panel of experts discussion, and Miriam will give the closing remarks. Thank you to both of you for all your support and input. Our panelists include a wide range of experts in the area of gender and mental health, and I wish to welcome After Tulip Briggs from Rethink Mental Illness, Salome Magura from Akidwa, Angelica Verk from the European Psychiatric Association, and last but not least, Maria Lorena Dini from Charité. We look forward to hearing your diverse range of expertise and insights during the discussion. To our online participants, thank you so much for joining us. I would encourage you to engage with the discussions, and if you wish to ask questions, please put them in the Q&A at the bottom of the screen. So without further ado, I would like to introduce Deirdre Clune, who is a member of the European Parliament for the constituency of Ireland South, having been elected in 2014 and re-elected in 2019. She's a full member of the Parliament's Committee on Internal Market and Consumer Protection and a substitute member of the Environment, Public Health and Food Safety. Deirdre, I hand over to you.
Yes, thank you. Good morning. Thank you, and good morning, everybody. I'm delighted to have the opportunity to host this very important webinar, The Interplay of Gender and Mental Health. And it is a global health issue. So it's organised with the European Institute for Women's Health and the European Psychiatric Association. And I suppose before the COVID pandemic, 1 in 6 people in the EU suffered from mental health issues. We know this, and the unprecedented crisis experienced over the past years, including the war in Ukraine, has placed enormous additional pressure on people's mental health, especially among women, young people, and those who had a pre-existing mental health condition. Women face unique barriers to good mental health and multiple levels of discrimination. A life course approach helps us better understand the unique challenges that face women. From a young age, women are more likely to suffer from an eating disorder compared to men. This mental health condition often results from societal pressures placed on women and on young girls to conform to a specific body type, and dieting procedures are heavily marketed to women. And this issue brings in 2 very important determinants of health, the societal and the commercial. And so it is important that these are addressed in our pursuit of good mental health for everyone. Women are disproportionately affected by gender-based violence, including intimate partner violence, sexual harassment, and sexual assault. And globally, 1 in 3 women experience physical and/or sexual violence in their lifetime. And this takes a profound toll on the mental health of the survivors. Prevention strategies must be put in place, and comprehensive and culturally appropriate supports must be available to all those that are impacted by this violence. Maternal health evidence suggests that Perinatal depression affects as many as 1 in 5 pregnant women, and despite its prevalence, many challenges surround the diagnosis, treatment, and support of depression, including stigma and under-resourcing. And furthermore, there's a lack of information regarding the safe use of medication during pregnancy and lactation for both women and for their healthcare providers. So women are disproportionately diagnosed with depression and anxiety compared to men. And the gap in depression appears to widen with increasing age. For those aged 65 and over, almost twice as many women report chronic depression compared to men. So it's important that intersectionality is addressed in policy and public health. The LGBTQ+ community, ethnic minorities, refugees, homelessness, and other marginalised groups have specific mental health needs that must be taken into account in policy development to improve the mental health for everyone. The European Parliament's Public Health Committee recently drafted the first report on mental health, which was presented to the committee in recent weeks, and we are now in the process of amending and discussing that report. It was a response to the European Commission's communication, A Comprehensive Approach to Mental Health, which includes 20 flagship initiatives and 1.23 billion in funding. This approach is guided by 3 salient principles: adequate and effective prevention, accessible and affordable high-quality mental health care and treatment, and reintegration into society after recovery. And finally, as a member of the European Parliament's Women's Health Interest Group, I have a strong commitment to promoting and supporting gender equity in health across the life course, and believe that gender awareness should be embedded in the development of health policy. We must ensure that all women, no matter what age or background, have access to gender-sensitive mental health services wherever they live. And this Women's Health Interest Group, organised by the European Institute of Women's Health, will advocate for a EU strategy for women's health, ensuring that women's health remains a policy priority and receives the necessary attention across the healthcare continuum, from the design of research protocols, disaggregated data collection and analysis, right through to the delivery of the services. So we're very fortunate to have a number of expert speakers and guests with us today, and I really look forward to the discussion and to hear how we can strengthen the gender perspective in mental health policy and support the development and implementation of gender-sensitive treatment and care for all women in Europe. So I really look forward to the discussions, and thank you, Peggy, for the introduction.
Thank you very much, Deirdre. I would now like to introduce our keynote speaker. As I said before, she cannot join us live, but she has sent us a video. So Dr. Lazzari has been the Regional Advisor for Mental Health at the WHO Region Office for Europe since 2021. A native of Albania, she trained and worked as a psychiatrist in her home country, contributing to the education of medical students and later to the national reform of mental health policy and services. Having joined WHO in 2000, Dr. Lazzari expanded her scope of work beyond the Balkan region through her work in the mental health project of the Stability Pact in southeastern Europe and later in Turkey, where she led a large EU-funded WHO project on improving services for people with disabilities. We can now play the video. Thank you.
Good morning, and thank you to the European Institute for Women's Health and to the European Psychiatric Association for inviting me to represent WHO's perspective on the interplay between gender and mental health. Before I go to the key messages that I hope I can pass along today, I'd like to inform you that WHO Europe, having established mental health as its flagship priority, operates its mental health vision under the European Framework for Action on Mental Health, which timeline goes from 2021 to 2025. And in order to operationalize its vision, WHO Europe established also the Pan-European Mental Health Coalition, which I hope some of you are members and are familiar with. That is a collective gathering of more than 300 partners from all across Europe of mental health professionals, policymakers, persons with lived experience, mental health advocates, academics, representatives of sectors such as education, such as finance, dance, and sports and youth and so on. And the coalition, of course, one of its priority actions is to support the design of a transformative agenda for mental health systems and services in Europe. And certainly, to transform services, you cannot do that without considering all aspects that impact how services are designed, but also impact how people receive those services. And in this frame, gender is a very important a dimension of our work. So to start with, my first key message is the epidemiological divide. Many of you are very well aware of the important gender divide when it comes to the epidemiology of mental disorders. We have the burden of mental disorders across the world is very high. 1 in 8 people worldwide suffers from mental disorders at any moment that we speak, and out of those 1 in 8, 52.4% are women, and the rest, 47.6%, are men. Now, this divide cannot be explained with biological factors only. Of course, there is a combination of what we call social determinants of health that are indeed a combination of factors such as gender, such as education, such as economic situation, housing, employment, and so on. Now, when it comes to socioeconomic situation, there is ample evidence, and I hope you all agree to that, that women are experience usually disadvantaged socioeconomic status. They experience a tremendous gender gap, a tremendous pay gap, especially in certain pockets of the world. But the pay gap is important all over the world. They experience, of course, violence, intimate partner violence, sexual violence, or violence of any type, and all those are known to be very important risk factors for the development of mental health conditions. And as those are not enough, we saw COVID-19 having an impact on mental health, with a documented at least 25% increase of disorders such as depressive disorders and anxiety disorders. But we have seen that women were disproportionately affected during COVID-19. Now, again, why was that? We will have to attribute that gender divide in the COVID-19 impact on mental health to a combination of factors that take into account the social economic determinants of health. We have seen, for instance, that women were more affected of those disorders, but we have also seen that, for instance, professions that are typically female, such as health nurses and midwives, were also affected by an increased incidence of those mental disorders during COVID, which continues to this day. Now, when it comes to, again, discussing about the gender considerations in mental health, we have seen, for instance, the WHO World Mental Health Survey has found that the gender differences in rates of depression have narrowed in countries where roles of women and men became more equal. So we can very clearly see how, indeed, closing the gender gap has an impact on improving mental health of women, and closing also the gap, the mental health gap in between the genders. We have also seen that the prevalence of the depressive and anxiety disorders can be about 50% more common among women than men. We have also seen that there are certain disorders that are exclusively for women, and those are predictably the perinatal related disorders, depression during pregnancy, but also the postpartum conditions such as depression and psychosis. And also we have seen that when it comes to the life course approach, or to the life course term, we have seen that depressive disorders in older age are affecting more women than men, with very clearly 14%, more than 14% of women over 70 are found with a mental health condition, as opposed to 11.7% of men. So that would be my main message in terms of in terms of discussing epidemiology and gender divide. And why that is important, why I stopped here, is because no action can be taken to respond to the mental health needs of the population unless we consider the gender divide. We cannot design one size fits all services, and that is very clear now also with the proliferation of, for instance, digital solutions towards improving health and in this frame mental health of the population. We have to consider a number of issues, such as, for instance, also the fact that worldwide it is found that women use less internet than men. So when it comes to adopt and embrace digital solutions to improve health and mental health of the population, we will have to consider this gender divide. Now, I would like to go to my next key message that is related to the health and care workforce. And why that is important for for this discussion is that, as you very well know, health and care workforce is predominantly female. Now, it's true that we have witnessed an increase of female representation in the medical professions, especially across the physician, the graduated physicians, from, for instance, 42% to 48% today. But we still have an overwhelmingly a female healthcare profession when it comes to professions of nurses, midwives, and also lower paid jobs in the healthcare sector. This is very important because, as we have seen, healthcare workforce was particularly vulnerable during COVID-19, and there is more and more evidence coming in that indicates the impact in the mental health of the health workforce that COVID-19 had. Now, COVID-19 uncovered indeed a problem that was lurking there, for which we had started to become aware just before COVID. That was the loss, the continuous loss of the health and care workforce due to a number of factors. Of course, the easiest answer to the fact that we are losing medical personnel is to some countries argue that it is due to lower salaries. But this cannot be the only factor. The other factors, such as career prospects or well-being, the subjective sense of well-being and finding motivation at work, is as important when it comes to trying to find an answer of why we are losing our health and care workforce. And it is very important because we have to consider that our health and care workforce, being predominantly female, is indeed exposed to a number of responsibilities that in most societies fall onto women. While they still are having their work as healthcare providers, they still have to care for older relatives, for relatives that are experiencing health and disability issues, so that the burden on them is very high. And we have to be very mindful of how do we design responses to prevent the hemorrhage of healthcare personnel across the world. How can we improve strategies to retain healthcare personnel across the world? And therefore, without having very clear gender considerations into how can we make it easier for our healthcare personnel to continue working, we will not be successful. And this brings me to my third key message, that is the informal carers. Now, of course, I mentioned healthcare personnel being both formal carers as paid personnel in healthcare services, but also informal carers when it comes to having their families and relatives who are experiencing health or disability issues. But that we have to also remember that with the loss of healthcare workforce, this is compensated, or there are efforts to compensate that loss by the family members who come in the role of informal carers. And those are, again, typically females. In most societies, those are nearly exclusively female, but I can say with certainty that worldwide, regardless where you are, the informal care role is typically played by a woman, or by a female member of the family, be that a daughter, a sister, a mother, and so on. And that is again very important if we want to focus on how can systems support informal carers. We will have to take into account the fact that informal carers are typically overwhelmingly represented by women, and therefore no actions can be successful if gender sensitive and gender positive actions, gender positive budgets are not enforced to mediate and to mitigate those concerns. With this, I hope I have been able to pass along a number of messages that can serve for the discussion later on today and in the future, and I'll be very happy to be contacted for further collaboration with any of you, either in your individual positions or as representatives of your institutions. Thank you again for your invitation and have a very nice continuation. Thank you.
Good morning. I'm not quite sure if I should start now, but we had a wonderful introduction by Lydia Leslie from the World Health Organization, touching upon nearly all the subjects that we are going to cover with our wonderful panel. And I'm very happy to introduce them to you. We'll have 2 rounds of questions, and please feel free to punch in questions or remarks in the Q&A. And if they are directly related to the one who's speaking, I'll put them there, and otherwise we'll keep them for the general discussion. We have just about an hour. The 4 panelists we have are going to cover different areas mentioned before. Dr. Angelika Wiek is a honorary perinatal consultant psychiatrist at the Greater Manchester Mental Health NHS Foundation Trust, and a honorary senior lecturer at the University of Manchester. She's been chair of the women's section of the European Psychiatric Association for many years and serves on the editorial board of European Psychiatry and the Archives of Women's Mental Health. Her research and publications are in reproductive psychopharmacology, psychoneuroendocrinology, and perinatal psychiatry. Great welcome, Angelika, if I may call you by your name. Then the second one, from the user's perspective, is Afra Tulip Briggs, who is vice president of the wonderful Rethink Mental Illness Board that was founded by the father of a boy with schizophrenia, but has expanded its activities. And she's a carer for family members living with mental health illness and used mental health services for a number of years. Welcome, Afra. And then the third one touches on a very important issue of refugees that we will be hearing about more. Dr. Salome Mugua, I'm really sorry to mispronounce your name, is a researcher, gender equality activist, and human rights advocate, as we all should be, but she's in particular. She's the CEO of AKI DWA, the Migrants Women Network in Ireland, and founder of the WISAHA, the African Diaspora Developmental Organization. She serves as a Human Rights Commissioner with the Irish Human Rights and Equality Commission. A warm welcome to you, Salome. And finally, we have Lorena Dini, who graduated as a medical doctor and gained experience in primary care. And she obtained a Master of Science in International Health and a PhD at Charité, the University of Medicine in Berlin. In the past 5 years, her research has been focusing strongly on women's health, with a particular focus on women 50 plus, so menopause. She's currently expanding the design of gender-responsive healthcare and gender-sensitive research and the connection between women's health and One Health, and promoting integrated multidisciplinary coordinated care. And we all know that there's no health without mental health. So that's what we're going to focus on now. And if I may start with you, Angelica, we were wondering, are there sex and gender differences in the prevalence and the manifestation of mental health illnesses? Does it, in other words, affect women more than men?
Yes, thank you very much, and I'm very glad to be here. It's obviously an extremely important topic, and I think the movement towards individualized diagnosis and healthcare is a very important one to make our health systems more efficient. And one basis, of course, are the gender differences. And a lot has already been mentioned by previous speakers, highlighting particularly the difference in affective disorders. The depression, first of all, but also anxiety disorders are more common in women. And it really starts from childhood. In childhood, boys have been found to have more commonly conduct disorders than girls, and conversely, girls have been found to have more commonly emotional disorders than conduct disorders. So it starts really very early. And then there are many other differences which show up very early, like, for example, autism. Autism is thought to be approximately, and these studies all differ a little bit in the gender differences. Boys are thought to have about 4 times more commonly disorders on the autism spectrum. And they also are more commonly suffering from ADHD than girls, although we think maybe it manifests itself differently in girls, and maybe it isn't as often recognized in girls. And of course, eating disorders have already been mentioned. There's a large gender difference, probably about 10-1, something like that. And then in adolescence and in adulthood, we see, in addition to the differences in the common affective disorders, we see differences in schizophrenia. Schizophrenia tends to have an earlier onset in boys, and the course of schizophrenia is more severe in males than in women, tends to be more benign in women, and women also have more affective symptoms as part of their symptoms of schizophrenia. And men tend to have more often negative symptoms, the so-called negative symptoms, or rather absent, an absence of behavior that is regarded as being positive. There are differences also in suicide. Women more commonly present with suicide attempts, whereas men more commonly complete suicide. Men are also thought to more commonly have substance use disorders and antisocial behavior disorders. And again, that ties in with what you see in childhood, where boys have more the so-called externalizing behaviors or externalizing disorders, where their distress is expressed more outwardly, whereas in women it is more directed inwardly, i.e. with depression. Of course, the frequent or the high prevalence of domestic violence affects women in their mental health, but of course this is rather a cause of mental disorders than a prevalence of disorders itself.
But could you extend that to post-traumatic stress disorder?
In terms of the prevalence?
Prevalence, yes.
Yeah. I don't know an awful lot about post-traumatic stress disorder, but I could imagine that women do perhaps more frequently react to traumatic events, and maybe also report more often affective symptoms than men would do.
Yeah, because that's bringing us to our second panelist, Afra. What we realized with the Alliance Gender and Mental Health in the Netherlands is that the access to mental health for traumatized women often is more problematic, and that the fact they internalize a lot gives problems. And so I was wondering, Afra, what are some of the issues that women face when accessing mental health services, and how could they adapt more appropriately to women's needs or gender-specific needs?
Thanks, Rutger. I think that, as already mentioned, women are often economically, socially, affected, and that puts people already in a weaker position in terms of the power they feel they have and their ability to advocate for themselves. I think there is often an attitude, or there are things that women should be able to carry on with, and so there can be a stigma to asking for support because people feel that they should be managing this on their own, they should be capable of doing so. So unfortunately, women can be quite unwell by the time that they enter mental health services. So we need to make sure that we have a community approach where we're really encouraging people to talk about their issues early and to get support, but also to ease of access into services, so reduce waiting times so that people are getting the help they need. And I think as well, we really need to remember that once you've had a negative experience of a mental health service, that really does put people off going out and asking for more support and more help. And at the moment, a real big issue that I'm hearing about in the UK is women not having access to sanitary supplies around their periods. And that's really affecting their dignity. It's affecting who they are as a human. They don't feel like they're respected as a person. And so they're actually really worried about entering the mental health services again. They're really worried about going back into a psychiatric unit. And that's something that we could really easily support people with. And I think that healthcare systems really, really need to truly embrace co-creation, co-production. Quite often we see it as a exercise where people have gone out, they've done a survey and they think that's enough, but it needs to be that full feedback loop. It needs to use patient groups such as Gamian, who asked me to speak on their behalf today, because professionals are going to promote the services, but it's patients who it's going to affect ultimately. And it's so important to recognise the cultural barriers that women can be facing when entering mental health services, not just from migrant communities, refugee communities, but the communities that create inside communities. So a group of Polish women who may have been born in Britain, but actually they are still Polish in their heritage. They have their own ways of doing things. I don't think everything has to be a formal meeting and a formal listening session. I think people quite often will raise issues when they're going into their therapy appointments, when they're talking to their clinicians, and that actually we need to be better at logging that and working on it in separate spaces. I know from my own experience going into mental health clinician rooms, there were problems sometimes where there was an implied power dynamic from the layout of the furniture. The clinician was sat one side of the desk, my chair was lower than the clinician's. And all those things seem really minor when you're well, but actually when you're feeling very, very insecure in yourself, you're not feeling like you're worthy of anybody's attention, those things amplify. So it can be really helpful to actually just have some users of the space tell you what is causing them issues. Is it the art? Is it the way the furniture is? And moving those things to make sure that we're not creating a further imbalance.
So it's really respect for some details in the way you engage with people. You were naming the role of the community and co-creation. Could you elaborate slightly more on that? Because I think that's a very important issue. As we heard in the keynote lecture, we are facing personnel shortages, so the co-creation is not only a luxury, but it's going to be a necessity. So what is your view on that? And where are the options and the possibilities?
So I'm a really big believer in co-creation and co-production. I have seen firsthand, as somebody who works within the health service, as well as somebody who has sat on the other side of the table and been a user, how much of a difference it can make in recognizing there's a different way to do things and recognizing the small changes that we can all make to make a service more efficient, but also to make sure that it is reaching the aims that we want it to. And I think the use of the community is really, really important in this, because there are some people who are not going to be willing, if they see a poster offering a service saying, you can come and tell us what's wrong, that aren't going to feel comfortable doing that. They worry about whether there's going to be any repercussions on themselves, how their treatment's going to be affected, if they're going to be seen as a bad agent who doesn't want to get better. So using charities, using community groups, going to people where they are and where they feel comfortable can help you reach the groups that you're not representing well, but it also can help you just ease people into that experience of going, we are really serious about wanting to improve this, and we know that we need your support to do so.
And what are your ideas? Because you were talking about prejudice on privacy and on secrecy. How can we combat that?
I think that people will see if something is genuine. So in my experience, if people have raised a concern and that concern's been listened to, they have the evidence of something changing, people are more willing to come forward and go, okay, actually, I'm going to raise this bigger issue. So it can start with the smallest of things. It can be taking the horrible picture of ducks off the wall. It can be making sure that patients have access to Wi-Fi, or a choice in the colour of the seats so the waiting room looks a little bit friendlier and less like you're in a really clinical space. Okay. And that is how you build the confidence then of communities to really engage on those difficult subjects. But I think importantly, we have to be aware that when difficult subjects are raised, when somebody says something is harmful to them, that the healthcare service can't get defensive. It needs to be willing to engage and to accept that maybe there are things that they could have done better. And that could be a really difficult and uncomfortable position for a professional, but it's such an important place to reflect on.
So professionals really have to evolve and change their mindset from offer to looking into the demand. Yeah. Well, thank you very much. We're going to move on to Salome. The big vulnerability of migrant women has been named several times already. And what are the mental health challenges faced by migrant and refugee women? And does that give inequalities? And how can we respond to that, and especially make our policymakers respond to that?
Thank you. Thank you very much. I think those are three very big questions, and I didn't want to be in line with my previous speakers who have highlighted some of the issues that I was actually going to talk about. But just even from the outset, I just want to say that, you know, from my organization, Akido, which is the network of migrant women, we've been working for the last 21 years with migrant women who comes into the country from different parts of the world. I also want to make it very clear that the women that we work with and that we represent as migrant, using that terminology migrant, are not a homogeneous group. Because you're talking about refugee people who might have arrived yesterday, asylum seekers who arrived yesterday, but refugees who are brought as program refugees into a country for a long time, or the migrant who came, you know, for a long time, but still don't feel as part and parcel of still the wherever they are living. So really marking that that group of, you know, migrant are not a homogeneous group is very important. My organization had to remask the word mental health. And again, it's because of the terminologies and the wordings that we use when we are dealing with migrants, you know, and trying to address the issues of mental health. Because of, you know, sometimes it can be stigmatized. Sometimes, you know, it's normally taken very differently from different diverse background on what you mean by mental health, or when we say somebody has a mental health. We carried out a research, for example, in my organization in 2020 at the beginning of the COVID, and what we learned actually from the over 8 women that participated in that, they were mixed, but mainly refugees and women who have just arrived as asylum seekers. What we learned was that all of them had mental health issues. They identified mental health issues in their, in the description of what they were talking about. So in our project, we had to remask the word mental health to Let's Talk. So we use Let's Talk quite a lot. And I would be referring you to our website. We have actually that research, the whole complete research on issues of migrant women, health, mental health on our website, www.akidwa.ie. But from that, what we have learned and through our work is that mental health is a social issue, and migration cut across all the social determinants of health. So you cannot actually just say that, a migrant woman mental health is just affected because, she's not able to access, employment. There are so many other issues, that we look at individual levels and at level, community level, because the community is very important in terms of even supporting the mental health and well-being of anybody, regardless of whether they are migrant or they are not. The separation from their family, they're separated, from their families that they knew and that they were used to, and they have come to a country where they know nobody. The immigration journey in itself, it's very, very complicated. And most of the women, sometimes they experience a lot of, different experiences. My fellow person who spoke earlier mentioned about the sanitary towels, people finding them in countries of destination. It's very difficult from when women are on transit. They may not have the currency of where they are to be able to buy such sanitary, even if they have it, or they may not have a way of supporting themselves. But also, vulnerability, especially of women who are exploited, mainly, women who are being trafficked around or who are on the immigration journey, and they have actually to be abused or attacked, and even the experiences of what happened before they even left their countries. We have a lot of women now, who have come from Afghanistan, Syria, Ukraine, Africa, different parts of the world, who have actually been already very traumatized because of the war, conflict, and all this. So we also need to account into all this, that level of social exclusion when they head up into wherever they head up, based on what they had experienced before, the experiences, xenophobia and discrimination and racism, in countries of destination, stigma in host countries as well, they are looked differently, availability of migration-friendly health services. We know the challenges. I know the challenges we have here in Ireland, for example, of the provision of those health services. It's very, very difficult. Then, we have a big problem, if we want to talk about it really very freely, about the structural and systemic structures that we have in our own European countries, and how we treat refugees and asylum seekers and people seeking international protection. Quite often we keep them for a long time before their cases are determined. This increases the level of their mental health and worsens actually their condition. And this is what we are seeing actually here in Ireland. Women who did not even have mental health issues as per se as such, ending up in very bad situation. Quite often, again, some of the structural issues that need to change, because you asked about the policy, is the right to work. Being able to work gives people the mandate to be able to feel, they have their self-worth, or they are contributing, they are doing something. But quite often in some countries, for example, here in Ireland, people are given the right to work after 6 months, and those 6 months could be 9 months that you can be given the work permit, because by the time you apply and you do all this, and it just started actually in 2017. It has not been there for years. But also, access to, employment, voluntary work, which can help people to be able to engage with others and be able to contribute positively in a meaningful way in a country now where they choose to be, part and parcel of that country, is very, very difficult. We also have discriminatory policies. Like, for example, here we use the habitual residency. The habitual residency policy is if a woman is in an abusive relationship, and she's actually an asylum seeker or a person seeking international protection, or she just arrived, as migrant worker or a student, they cannot actually access the welfare support of the state because they have not been in that country for 2 years, and yet they are still also in their process of claiming for international protection. So some of these policies that we have in place also add into the trauma, adds into mental health, and into all these struggles that we are talking about of migrant women specifically, because those structural kind of systems that we have in place impact quite a lot, and it actually triggers even the trauma they had before, and those who didn't even have mental health problem issues, it brings into their problem, bringing children into an environment where you do not have support structures, in an environment where there are also laws and policies that says differently from wherever you are coming from. I know I'm running short of time, and I will come back
No, it
into
doesn't
that.
matter. No, to my shame, I must admit that the situation you're depicting in Ireland is very similar to the one in the Netherlands, where people are denied to work. And we saw the contrast when the people came from Ukraine. They were allowed to work straight away, which showed that giving autonomy was so important. We have one question from Isabel Isakulian, who asks, which mental health conditions is the most common in female refugees in the last decade? Would you have an answer to that one?
I didn't actually get that very well. What mental health
conditions are the most common in female refugees?
I wouldn't actually have, that, but from our understanding and from our work here, is that we understand that most of the women who have the mental health issues, they would end up in the mental health institution, and they would be under medication, and they would be under that. But we have seen quite a lot in our work is depression. It wouldn't be like a mental health as per se that is it's just sphere mental health. It would be mainly those depression or stress that adds goes into that mental health, which would make women to end up being medicated in all those things. But finally, I also wanted to mention about, Deirdre mentioned about the culturally appropriate support and services that, service providers need to understand, that we have to be culturally appropriate, and we have to take this vulnerability assessment, because I think Afla spoke about the waiting list, for example, in UK. But rather than having the waiting list, why can't we do this vulnerability assessment from the very beginning when people come into the country, and we get to know how they can be helped from the very beginning, and then have a lot of training and education for our service providers and frontline services to be able to understand about the migration as also a cause of social determinant of mental health of migrant women, based on what they might have faced on their journey, or even when they're in the country, because exploitation and discrimination doesn't end on the immigration journey. It's also actually worsens even when they're in country of destination.
Thank you very much, Salomon. And we're going to move on to Lorena. And Lorena is going to highlight a very different aspect, well, very much in line, but you're focusing on postmenopausal women for 50 plus. What are some challenges that you're meeting, and how can we support them best?
Yes, thank you very much, Luca, for the introduction. And I'm fascinated by this exchange and the keynote and what is coming here together. With this initiative, the European Institute of Women Health and the European Psychiatric Association have really bridged two things that have shown to be very important. I'm working in Germany, as you were saying, with older women 50 plus. And discrimination, as my previous colleagues were saying, is not ending only on race, but also on age. So we have really a challenge about the providers, the healthcare providers. I'm focusing on general practice and gynecologists, and we conducted a survey to see are they willing to share tasks? Are they willing to engage together to provide services? And regarding the mental health aspects of that, we have, of course, sexual health, depression, menopause, as you were saying, but also anxiety, worries, and the economical burden produced also by family change in these phases across the life cycle that women face, of course, and poverty in age. So there is a lot of issues that are there still to be bridged. And of course, not only the qualification, but also the empowerment of the health practitioners themselves on the one side, and the empowerment of the patients on their own on the other side. We have like these two insecured from each other at the basis when we are trying to bring the policies to the people, right? And in that continuum to bridge the communities, we need the GPs, we need the gynecologists, in order to reach out with this mental health services and provisions to those in need, and also to find out and to be able to funnel them into the appropriate services. We have found in the Frauen 5.0, that's Woman 5.0 project, that that GPs and gynecologists in Germany working at ambulatory care level were willing to provide advice, but they do not feel that comfortable in diagnosis and in treatment of this kind of issues, of course. And when we ask the women, they were also not feeling like talking themselves about those issues, about sexual health or all those things, because also due to the respect of the professional's time and do not feeling that important or having like the room. So I was thinking also when Afra was saying, how do we understand safety for the patient in our offices? What is really to provide and create that safe space of sharing, understanding where healing or health can emerge and be provided? I think that's a crucial point that we have to dig into. And in this webinar today, we're bringing two aspects. One is of the mental health at individual level, but we're also with the gender dimension and perspective, bridging it to the social dimensions as was referred before, and all those pressures. What is like a woman? How do we have to look like with 40, with 50, with 60? And we have all this social media and television and movies, sometimes featuring an actress 30 years representing a woman 50. So everyone thinks, oh, that's like with 50, you have to look like that, but that's not reality. So we have like a whole pressure of society, of family, own insecurities being fueled. And I think that's a huge field where mental health strengthening and empowerment can play a crucial role in getting things better or right.
I was just wondering, and that's bringing me back to Angelica shortly, but I wanted to ask you, Lorena, I've been reading recently on the worsening of schizophrenia in women after menopause, because the protective aspect of estrogen drops down. I was wondering, is that an issue too, the difficult pharmacology, or should we go to Angelica to answer that question?
Maybe Angelica will have the data on that.
Thank you very much. Yes, it is interesting because there are quite a lot of, just looking at the pharmacological side, there are now certainly studies which have shown that women's plasma levels of antipsychotics, which you use for the treatment of schizophrenia, are higher than in men. And it is thought that it is mostly to do with liver enzymes, which are influenced by estrogen. And then when in the menopause, when estrogen production, or the perimenopause, when it declines, so you would have a poorer response to antipsychotics. Okay. So that's one reason. And another one is that maybe intrinsically around the perimenopause, you have got higher rates of new onsets of schizophrenia. So there might be other effects of estrogen, not just related to the plasma levels, but maybe other effects relating to direct brain effects.
Okay, because this brings me to other questions about the pharmacology. A lot of the drugs have only been tested on men, and one supposes that they work in the same way for women. But is medicine safety in pregnancy, or treating postpartum depression of breastfeeding women, are these issues that are challenges, or are they being met these days?
That's again a very interesting question, and we have seen a very positive development in this area. Research has vastly improved in this, because 20 years ago we hardly had any good research to rely on when we faced the very and the patient and the women themselves faced the very difficult question whether they should continue psychotropic medication in pregnancy. And there has been a tremendous advance in the research of whether antidepressants are safe and whether antipsychotics are safe. But there has been less research for drugs like lithium, which is used for the treatment of bipolar disorder, but also other commonly used drugs like benzodiazepines. There has been less research. But I think what we have learned from these last 20 years, and by the way, this progress has been possible because of the improvement of statistical methods and having very large databases, and sometimes the databases of huge numbers of people are being combined from several countries. So what we have learned is that in the past, it was reported that antipsychotics, for example, had a twofold increased rates of congenital malformations, but we have learned in recent years that this is probably due to other factors. And when you take these other factors into account, then this difference disappears. So it seems that antipsychotics are not major reasons for children to have congenital anomalies, and the same applies to antidepressants. And then, of course, there are some other important aspects. How can these drugs, for example, affect pregnancy outcomes, or can they affect the longer-term development of children? And again, we see more and more very much better studies being published, and they mostly go in the direction of reducing previous estimates of harm. And there's one exception. There's one exception, of course, it is valproate. Maybe most people who are attending this webinar will know about it, but valproate should not be taken by women who have mental disorders in pregnancy. That is very dangerous for unborn children.
Yes. I was wondering, does the underdiagnosing that you mentioned for developmental disorders in girls also go for postpartum depression, for instance?
Yeah, I mean, first of all, I would like to say that it's a general phenomenon in the whole of psychiatry that some common disorders and some of the more severe disorders are underdiagnosed, but it certainly also is an issue in depression. And I would like to include in that not just postnatal depression, we also have an issue, and probably greater issue, with antenatal depression. It is thought that 50% of women who have antenatal depression will continue to have depression after childbirth. So I think that is a very important issue. Everybody talks about postnatal depression, and they think, by the way, that it is the whole of perinatal psychiatry. There are many more disorders in pregnancy and postnatal which are important too, but antenatal depression should not be neglected. Okay. Both conditions are underdiagnosed. There are many different reasons for this. It is the lack of training. It is the lack of good screening instruments. There are no good screening instruments. And in the moment, it is thought that an introduction of national approaches, for example, for screening, wouldn't bring much advantage, for example. So we need to have a lot more research for this to improve the situation. Yeah,
thank you very much. Isa Toussar on the Q&A is addressing a couple of issues on the sustainable developmental goals and policies. So we're going to come back to that in the general discussion, or maybe Salomon can touch upon that. But I wanted to ask Afra, what should policymakers do to support women and families that are often the carers for family members with mental health problems?
I think first and foremost, we need to remember all the different things that women have going on in their lives. They might be working, they might be keeping the house clean and tidy, getting the shopping in, taking children to school, and providing those caring responsibilities. And we need to therefore consider actually how easy it is for people to navigate those systems. I know that in the UK, the benefit system, the welfare system can be quite complicated. And then if they're feeling like they have to advocate for the person they're caring for as well, the mental health services are just as complicated. And people say, I only have 24 hours in the day, and I have to spend 4 hours on the phone to the benefit service and 4 hours on the phone to the mental health services to get the person I'm caring for extra support, when I'm meant to do everything else. So I think there is a really important thing that everyone needs to look at about ease of access to services. And as part of that, there's often the complexity around when somebody has a concern about the person they care for, and they're trying to contact the right mental health team to raise that concern, but they get pushback because of patient confidentiality. And actually, the carer is with somebody for many more hours than the clinician will be with them for. They're going to see things that the clinician isn't actually aware of. And we need to make it easier for people to be able to report in that there is an issue. It doesn't mean that we've got to share there and then information about the patient. There's nothing to say that the clinician can't receive extra information and then discuss it with the team as to whether or not it's important. And I think in terms of information, it would be so much easier and better if when somebody starts a new medication, that we give out two lots of information, one for the patient, but one for the carer, to say, if these things are happening, we want you to raise the concern with us, and this is how to go about it. Or if you do not feel safe because of this person's mental health support, this is how you get access to additional services, whether that's through the state, whether that's through a charity organisation. This has got to be something we really come at as a community. It's not something we can do in the healthcare system alone.
So there's a lot of work to do to raise public awareness and to strengthen the users.
Yeah, I think that when you're feeling unwell, advocating for yourself is really difficult. Yeah. But that doesn't mean we can't build systems in to help empower you, to help make you aware of what information you're allowed to have, what information you're allowed to share, and also how you can build up your own confidence to be able to discuss these deeply personal issues with the healthcare provider.
Yeah. Okay. There are many questions pouring into the Q&A, but I just wanted to make the round and give Salomon and Lorena the floor on other topics. Salomon, we were talking about the professionals, and what would your advice be to the trainers of professionals, psychiatrists, psychologists, social workers, nurses, that should be included in the curriculum or the experience to make them better prepared to address the issues of migrant people and women in particular?
Yeah, I think, yeah, thank you. I think, training being included in curriculum is good, but at the same time, once people do the course, and then what? I think the training should be throughout the year. They should refresh the training, because things are changing. Everything is changing very quickly, and so it's important that the healthcare professional, frontline services, and everyone who come into contact with refugees and people from different background get to understand where they are coming from, different issues and needs that these people may have. But we also have other many problems, and I think the healthcare professionals and all these people being supported by what we call the intercultural mediators. Actually, my organization visited Milan a few months ago, and we found that they have this kind of multidisciplinary team, a team of social workers, team of healthcare professional, teams of gynecologists, teams working on issues of violence against women, all working together to be able to support the person, because the person may be one person, but they have so many other needs, you know, with them that also affect their mental health. I think that multidisciplinary kind of setup is needed by all this, you know, setup of healthcare professional, in addition to training, which we are saying that training should be consistent. It should be continuous. We also have a problem of language barriers, and I must say that before I finish, because I said at the beginning, from the very beginning, that migrant and refugees and asylum seekers are not a homogeneous group. Most of the people actually who end up coming to us have language problems. And the language problems can be the way you speak, but also it's what is written in document. They may receive a document, they may receive a be diagnosed, but they won't understand that because it's not their level of understanding. So all this has to be taken into account to be able to support that person fully. But finally, we need specialized services and support services, especially for people who have trauma, because we need trauma-informed services and support. We have one here in Ireland. It's only one, and it's a country of 5.1 million people. So these services need to be, you know, everywhere in counties, different counties. I speak this because I was also a co-president of the European Network of Migrant Women, and I also understand what is happening in different European countries. So really support for the individual is needed so much by the healthcare professionals, but also all these other people who support, you know, individuals and groups to be able to function and to be able to fit into the society.
No, the whole point of language is so important. You know, I remember many women that had their own children aged 8 or 9 as translators, you know, and how embarrassing it can be for a woman to talk about very intimate problems or that kind of things, and having their children translate. Before we move to the extensive Q&A, and I hope you'll take a look at that, and some of you may respond by typing, but we'll try to answer all those questions. Lorena, do you think the EU Commission's comprehensive approach to mental health is going to make any difference in improving the access to services?
I definitely hope so, because that's what action plans are for, to give us a vision and an inspiration and a pathway to move forward. But I firmly believe it's up to every one of us on how we contribute to the absorption of the strategies in real life. We might have a vision, but sometimes these policies get lost in translation from policy to practice, in translation from policy to communities, from policy to patients, and then we do not deliver as society the expected outcomes to the people in need. So I think this is what has led me to put up the topics now and moving those gender resilient healthcare systems development and gender responsive healthcare, because we have to change our approach and maybe also the narrative where we are based. Not starting from the point that being a woman or gender diverse person is a weakness, but it is just a different expression, let's say like that. But it has not to be necessarily a weakness in itself. Therefore, I think we have to change the understanding of the methods to unite. So I very much welcome the multi-sectoral approach and the patient participation into new policies, the focus on prevention, the connection with the NCDs. I think those things could really bring it, but it will depend on us as a scientific community, as healthcare providers, as women and as citizens, on how we can make sure that the funds will go to those most important actions. Sometimes contrary on the efficient and more, sometimes it's good enough, better than more and more of the same in a marginal increment of improvement. We need sometimes to think a little bit more about that. What does it really mean? Make one person fully good or make more people far better in their well-being as well, not only in the overall approach. And
So
it includes social cognition, of course.
So what you're suggesting that, say, the European Psychiatric Association and the Institute for Women's Health should have focused lobby on this issue, on these kind of issues?
I think lobby is very important, and also uniting uniting in the purpose of what kind of society of mental health structures we envision in the end. And that will bring us together, I think, to push for the right solutions also at European level.
Wonderful, thank you very much. Now we're going to move to the general discussion, and there are many, many questions, and I hope that one of you will give a brief answer to one of them, and otherwise we'll be prepared to type in an answer that we can share with everybody, because some are Isatou Sarr, for instance, has put in many, many questions. I'll just start with the first one. As policymakers begin to work to address pockets of health disparities, which is foundational to the achievement of sustainable developmental goals, their actions enter into the moral realm of political and ethical decisions in the way that place social justice at the center of their work. And that's something I think that, Salomon, you've been addressing, that these social determinants are absolutely core issues, and it was named in the opening lecture too, that pay gaps should be changed. And I'm moving to some other questions. Do you have any guides on healthcare for transgender people, vulnerable transgender women, in the context of WPATH standards of care, SOC 8? Does one of you have an answer to that? If not, we'll have to look for someone within our organizations. Well, steady employment, social connections, access to healthcare services have been named. So I hope, Isatou, that you had some answers to your questions in what our panelists have been saying. Are there any mental health impairment in women whose parents abused alcohol? And Deirdre, do you have any information on that? Fetal alcohol
Sorry,
syndrome?
did you mean me? Yeah.
Yeah.
Yeah, I think a lot is commonly shared with parents who abuse other substances, but you know, we have the issues relating from drug use, alcohol use during pregnancy, so there can be widespread impairments and congenital anomalies in the children. But then later on, of course, there is a lack of parenting, of good parenting, leading to all the complications that we probably would be too big to discuss now. And then children having to take on the carer role. I think there are many, many examples of that. Certainly, I've seen a lot in my clinical practice. And then also the other effects of alcoholism in parents, leading to separation of parents, the loss of family ties, etc., etc. So it's a huge range of effects that children can suffer when their parents abuse alcohol or other substances.
So basically what you're saying is that alcohol abuse during pregnancy is a major risk factor.
Yeah.
But the fact that parents abuse alcohol is a very strong environmental risk factor in upbringing. Okay. Yeah, thank you very much.
I wanted to come in on the one on sustainable development goals.
Yes, please.
Actually, yes, and having the experience of working with the state on this and individual, because you see, if we want to relate issues of sustainable development goals and what you're talking about, because all the 17 goals can help to better mental health. Actually, they are equal to what a person need to be a better person, whenever, regardless of wherever they are coming from. But our experience and my experience here in Ireland has been that SDGs are always looked at something of very, very far away from us. People are not looking at them like they're issues of developed world, if I want to say it that way. It's issues of developing countries. And so not unless even the policymakers and ourselves, each individual take it that they're issues for all of us, that we can be able to help improve some of the issues that we have. You know, we are saying that, you know, mental health is a social determiner. Social determines actually mental health. And when we look into the 17 Sustainable Development Goal, whether it's education, employment, you know, poverty, all these issues are the issues that affect individuals regardless of wherever they are coming from.
Okay.
And when we talk about refugees and asylum seekers, it's only because they're coming from other countries. And, you know, like, for example, goal number 10 and 11, you know, even climate change and all that, you're talking about them in the questions, would help if we get better understanding, but we also work on them in our own countries rather than looking at them as issues which are very, very far away from us. So I hope our policymakers take this very seriously and see how this can help to solve the issues of mental health.
Okay, and I have a question here on mood swings linked to hormonal changes and the interplay of psychosocial and hormonal factors in an increased risk for prenatal and postnatal depression. Is one of you willing to address that? What the role is of hormonal change during the menstrual cycle in relation to mood swings?
I can
yes,
tell
please.
you a little bit about that. I mean, I think we've always known that, that hormonal fluctuations are related to mood, but there have been a set of really fantastic studies coming from the United States of a group who is made it their goal to elucidate the effects of hormones. And what they have done is they have, in the menstrual cycle, blocked the effects of the ovaries. So the ovaries were not producing any hormones, and then they gave the women hormones, and they found that during the times when the hormones change, i.e. whether when they were introduced or when they were withdrawn, women had more likely mood changes. And the women who had premenstrual syndrome or premenstrual dysphoric disorder had more changes than normal, so-called normal controls. So this was a very good proof. And this very similar study has been done in women who have suffered in the past from postnatal depression. So I think that was almost a proof that certainly changes in the way that the body produces hormones are linked with negative mood changes.
Okay, we have two little questions that I would like you to address, and otherwise we can do that by typing. The first one is what to do to prevent traumatic birth as midwifery educator. And the second one is, do you think that more research should be done to better understand whether there's a hormonal link between women's and Alzheimer's? Could more effective use of HRT perhaps help prevent Alzheimer's? Lorena, is that your area? Well, not the traumatic birth, but the Alzheimer?
Whatever is research, it would love to engage. So I definitely think we have to conduct more research on Alzheimer, and why not? I mean, this is an hypothesis. We also can see if having more sex will be a prevention of Alzheimer, because that is what declines also after 50. There are many hypotheses, and I think why not? Understanding it better could help. And using of hormone repressed therapy, there is a body of evidence on that and a lot of research being done on that. And Angelica was describing as well the relationship between hormones and moods and many expectancies. So
okay, and preventing traumatic birth or traumatic birth conditions. Well, if not, unfortunately, we're going to have to leave it here. And I want to thank you, Angelica, Afra, Salome, and Verena, for your wonderful contributions. Thank you so much. And I'm sure that participants will be able to join you if they have questions in the second instance. And now we're going to close this panel discussion, and we're moving on to Alison Zucker, who is a researcher at the London School of Economics Care Policy and Evaluation Center. and focusing on long-term care, social care, mental health, and integration policy. And she's recently completed her master in health economics and is now focusing on women seeking international protection, mental health in the EU in partnership with the EIWH and EPA. So, Alison, you have a very short slot to make your point, but I'm sure you're going to be concise and precise. Thank you very much.
Thank you for the challenge. So this summer, I've had the privilege, as you mentioned, of working with the EIWH, learning about women seeking international protection in the EU. In this presentation, I'm going to share a very brief summary of the research, and we will be publishing a report this fall. And of course, if this sparks any thoughts, please reach out. We conducted a literature review to answer the following research questions. Why is there a need to address gender differences in people seeking international protection's mental health, that's refugees and asylum seekers, specifically depression, anxiety, and post-traumatic stress disorder? 2, what are some examples of mental health interventions and policies that respond properly to these women seeking international protection experiencing these common mental illnesses? To answer the first question on why, there are a few major reasons it is important for policymakers and leaders to focus specifically on women seeking international protection. The first, in 2015, Europe declared a migration crisis, and the numbers continue to rise. This is due to anthropogenic, human-driven conflict, as well as natural disasters and increasingly climate change. GDP growth is slower in Europe than in other regions of the world, and the migrant community actually has the opportunity to contribute to economic growth when given the resources. Now is the time because there's a current EU focus on mental health, as Dr. Lazzari shared in the keynote speech. The WHO, for example, has set out a European framework for action on mental health from 2021 to 2025. And then why migrant women in particular? Because they face additional barriers to access care, such as language, stigma, labor discrimination, economic dependence on their partners. And, lastly, these men and women manifest mental illness and stress differently, as Dr. Angelica and the panel mentioned. And often these women face different challenges to migration and integration from their male counterparts. For instance, women endure gender-based violence, sexual harassment, and exploitation at every stage of their migration journey. For these reasons, women seeking international protection require a targeted program and policy response due to these distinct risk factors and barriers to accessing care. So that's why, to answer the second question as to what policymakers and leaders can do, we distilled some common success factors across effective interventions in the EU. In terms of research and development, governments and NGOs can conduct a mental health screening upon arrival. The sooner, the better. All organizations can work towards data disaggregation and representation in epidemiological studies and clinical trials. In terms of access, a range of players can increase and contribute to increasing access to, this is a mouthful, trauma-informed, culturally competent, and language-specific care by reducing barriers for foreign clinical workers to practice, expanding peer mentor programs, calling in already trained cultural mediators. These are former refugees who have now integrated into society, trained by the International Organization for Migration, training healthcare professionals in gender and cultural competence and the impact of discrimination, and offering a wide range of in-person and digital options to meet the individual where they're at. All these things can increase access. In terms of awareness, policymakers can focus on destigmatization of mental health for women seeking international protection, as well as for Europeans integrating these new communities. In this way, terminology matters, and a few people on the panel discuss this as well. For example, we can shift the mindset from a refugee crisis to an opportunity to foster cultural exchange, mutual understanding, and collective social and economic growth. Lastly, in terms of cross-sector coordination, it is clear that mental health and the social determinants of health are inseparable. Policymakers, NGOs, health systems, social services, education sector can all work together, such as by including women-specific endpoints for this particular population in existing programs, and combining budgets, and which is difficult, but for language programs, sexual and reproductive health, and importantly, affordable and accessible childcare where appropriate. As Afra highlighted in the panel, all policies and programs must be guided by the voices of these women and co-created with this vulnerable population. I want to end with the voices of these women and a message of hope. There's hope for the future about us and our children. They want to give back to the communities that have accepted them. And there's a lot to do and a lot of hope there as well. So thank you. I know this is quick, but please reach out with any further questions or comments. And we're looking forward to publishing the report this fall. So back to you, Rutger.
Mariam, if you want to go ahead.
Yes, thank you very much. My name is Mariam Schuler-Rotschat. I'm the board member of the EPA and of the European Institute of Women's Health. I'm very happy now to share closing remarks with all of you. I hope you enjoy our webinar. So as we bring this Insight webinar to a close, I want to thank each and every of you for your joining this webinar. The level of attendance, participation, and engagement from our audience shows how important the issue of gender and mental health is, and I want to thank all of you for supporting our webinar. We have heard from remarkable and esteemed speakers and panelists who have shared their expertise on the many mental health challenges faced by women around the world and highlighted the need for gender-sensitive mental health services strengthened by gender-specific research, intervention, and policies. Models of good mental health policies and practice exist and must ensure that models of good practice are available to policymakers across the EU. The EPA, European Psychiatric Association, provided its input earlier this year in the frame of the EU call for evidence on a comprehensive approach to mental health. The EPA, both EPA and EIWH, look forward to working with Deirdre. I'm very happy that you are here, Deirdre, and the Women's Health Interest Group in the EU Parliament, and contributing to and supporting the EU Commission's comprehensive approach to mental health and promoting gender equity in health for all women across the EU member states. In terms of work conducted on women's mental health, I would like to mention the activities and events, for example, series of webinars that have been organized by the section on women's mental health of the EPA, for example, webinar on postpartum psychosis. I encourage you to continue the conservation in both your professional and personal lives and to take action to better support those experiencing mental health problems. Working together, healthcare professionals, as well as professionals, politicians, policymakers, and women themselves, we can break down barriers and reduce stigma to good mental health. We must work towards a more equitable and inclusive environment where the right to good mental health can be achieved by everyone, regardless of their gender. I wish to thank you all once more for participation in our webinar today. We have posted a feedback questionnaire into the chat box, and I encourage you to take the time to complete this questionnaire. We will appreciate really your feedback, as this will help us to plan future webinars or other events. This event was jointly organized, as mentioned before, by the European Psychiatric Association and European Institute of Women's Health. We are extremely fortunate to have signed, as mentioned by Peggy before, a memorandum of understanding, and we look forward to continuing our work together on the intersection of gender and mental health. You can follow the EPA on Twitter, Facebook, LinkedIn, and Instagram, or you can visit our website, www.europsci.net. The Institute of Women's Health is on Twitter, LinkedIn, and Instagram. And you can also visit their website, www.eurohealth.ie. You can read more about the Institute's manifesto calling for an EU strategy for women's health by following the link posted in the chat box. Please stay connected, stay informed, and let's prioritize women's mental health everywhere using the ethical principles of respect for persons, beneficent, doing good, non-maleficent, not doing harm, and justice, treating people fairly. These are cornerstones of modern ethical codes for the health professionals. Thank you very much again for all of you, for panelists, speakers, moderators, of course, the audience, and thank you very much to Peggy, to Tom, to Adrian, to realizing this webinar, and also for technical assistance and support. Thank you again. I look forward to meeting you in future events on women's mental health. Thank you very much and have a nice day.